My name is Jay Matthews. I'm an operating department practitioner, or shortly known as an ODP.
Hi, my name is Kathleen and I'm a trainee advanced clinical practitioner in the Paediatric Emergency Department in Manchester.
Hi, my name's Melanie Quinn. I'm an intensive care sister in Musgrove Park Hospital in Taunton, Somerset.
Hi, I'm Anthony Cook. I'm a registered nurse background. I work in Sydney.
So my name is David Anderson. I'm a humanitarian health advisor for UK Med. Previously worked in the NHS for 32 years as a senior nurse, general manager and nurse mainly in urgent and emergency care.
My name is Dr. Najib Rahman. I'm a consultant in emergency medicine based at Leeds Teaching Hospitals NHS Trust.
So my name's Paul Lawrenson. I'm a paramedic here at North West Ambulance Service in the UK.
Hi, my name is Pete Skelton. I'm Rehab and Emergencies Focal Point with the World Health Organisation. In the NHS, I was a physio working in central London.
My name is Rabal Ahmed and I'm a junior pharmacist at the Royal Bolton Hospital.
My name is Shama Khan. I'm an emergency medicine physician currently working at the Royal Oldham Hospital.
My name is Julie Wallace. I am a sister in the emergency department of Salford Royal in Manchester. That's probably about it.
I'm a trustee of a medical charity called Doctors Worldwide, which is based out in Manchester, and have a couple of additional roles at the Royal College of Emergency Medicine, one of which is where I sit on the Global EM Committee at the college, as well as the EM and Public Health Special Interest Group.
So I'm currently in Eswatini doing some coronavirus work.
In 2018, I deployed to Bangladesh with the UK Emergency Medical Team. I also worked with Raleigh International in 2015. I have also worked with Capital Air Ambulance doing aeromedical repatriations and retrievals.
I've been working in remote and austere environments. I've encountered global health face to face in both onshore, offshore environments, working with a multitude of different nationalities.
The emergency response I went to was a medical emergency around Sierra Leone and Ebola.
Been involved in some global emergency care initiatives in humanitarian and development settings.
I worked with MSF between 2012 and 2014. I worked with Freedom from Torture, which is an organisation that supports asylum seekers.
I worked at the Nagoya Daini Red Cross Hospital in Japan, which is a specialist centre for international medical relief and global emergency disaster response.
And we have 7 facilities that I am the disaster manager for. I'm an OSMAT team leader. I work for CareFlight part-time as an educator.
And I've been involved in humanitarian responses in a variety of different settings for the last 10 or more years now.
I am a full-time locum, allowing me to do global health projects, where I've been to Bangladesh, Guinea, and I'm currently in Lebanon.
So I think the work that we do when we deploy abroad is both very similar and very, very different to what we do when we're back home. So you work in much lower resource settings and have to be able to adapt to those settings and work within the context which you deploy, which means that you have to change the way you work, the way you feel, and the way and give utmost respect you work with.
I've really learnt the importance of the MDT and how everyone's got a different skill and practice to offer.
The teamwork in the NHS can at times be quite frayed and quite difficult to work within. Whereas actually, if you break down the barriers, the team works much, much better. So I spend a lot of time just supporting staff, identifying issues, ironing them out. And I'm better at that now, having the experience that actually, as a team, you can get through anything with very limited resources, with immense pressure. So actually in the NHS, we should identify that actually these things can be done. We just maybe have to look at things a different way, approach things in a different way, but the end result is the same, that we deliver the best care we can.
I was learning more by working within teams with colleagues overseas, trying to understand a common vision, trying to understand what the barriers were to achieve certain things, and essentially trying to speak a common language and get a more culturally nuanced understanding of the barriers to healthcare access and the barriers to delivering healthcare that my colleagues were facing internationally.
Skills that you pick up in the global health environment I guess, that I've brought back to my normal role are all around obviously communication and the importance of communicating with all levels of a facility and all disciplines. So that real multidisciplinary approach, and provide that leadership, that's really important when things are going wrong in a facility and site.
Basics are the same in that I work as part of a team, and establishing each person's role within that team and supporting them to deliver that role efficiently and effectively. So actually the role isn't that different. How I fulfill that role, however, would be completely different as a leader, probably in the ED department in Salford, whereas put in an environment in an emergency response, my role could be very different. However, the skills that I use in ED are completely transferable to any role that I could find myself in an emergency response.
We are trained to operate and function in this setting, and unless we put the same number of hours in another setting with the same kind of patient load and case burden, I think expecting that we'll be clinically as competent, is questionable. But I do think the transferable skills around working in groups of people, learning how to listen, learning how to collaborate and create ideas and innovate, and then try and find solutions and improve the way that is done, build more evidence around it, help train and build capacity to do that. I think those elements have duality. That then helped to refine some of my ideas around global health work and the improvement work that we now do in the NHS within QI or system strengthening. That actually, that's maybe where global EM and global health work become much more, I think, consistent, rather than saying that my clinical EM practice is directly exportable. Actually, maybe it's not that. Maybe it's skill sets in education, training, QI, system strengthening, and research, that is.
I've had 3 different deployments now, and they've been, 2 of them have been very much treatment and delivering care, and one of them, the one I'm in currently, is capacity building, which has been really good for experience. It's similar in some ways, in the terms that we have to still work with doctors and nurses and porters and cleaners around us. I think the topics probably vary a lot more. So I do a lot more in terms of infection control, and you get lots of different questions that aren't normally my remit. But also, it then extends to talking to hospital administrators and working in the community as well. The role doesn't just stop within the hospital. In the same way it doesn't just stop in the country. It is a global health work. And so I think really the scope is the difference. When you're in the UK, I feel like I'm much more in a smaller team and I work in that team. When I'm out here, or as I am in Lebanon now, the role expands quite a lot more.
Unfortunately, due to my experience during Ebola, I became the queen of PPE. Lots of it was the mindset that if I'd survived Ebola, I was going to survive COVID. So therefore, anything I said was taken on verbatim. Nobody questioned anything. If I said stand there naked, they probably would have done it. Massive effect on the department, because we very quickly organised the hot zones and the cold zones, how we were going to travel through the hot zones and cold zones, got everybody trained up on PPE. I included the domestics, the porters, everybody. There was one point of information, and that information stayed the same throughout. We got compliance from everybody, and it ran fantastic. And we had the lowest rate of staff infections in the trust.
Not only were we involved in staff development, but also in national systems development too. Our project focused on developing audit and feedback processes, data collection including mortality and epidemiology, etc., drug and stock procurement, and also process establishment, for example triage and malnutrition care. It's also given me some oversight into how I can contribute to paediatric emergency care out with just my local setting in Manchester, but also on involvement in national and international care initiatives.
ultimately in the UK, we have access to a huge amount of resources, and we are actually extremely privileged in the work that we do with the equipment, exceptionally well-trained staff, and resources that are to hand. When you work in countries that you may feel are very well developed, I was, for example, the clinical lead in Samoa last year for the measles outbreak, and even there we were very, very short of some crucial equipment that you would normally use to treat particularly children, things like IO needles and stuff, which you may take for granted in your commonly in emergency departments now. You know, there was a shot that we didn't have those, and then there's a shortage of the appropriate size cannulas. So that's just one example in a relatively well established health system. And if you go to another health system, for example, South Sudan, where I was teaching trauma, it's like really, really basic, but hugely inspirational place to work.
But it has made me more adaptable, better at working with what's available rather than what should be available, and managing sort of different ways to achieve the same goal.
It's made me a lot more grateful for what we have available in the UK. I think the general public also don't realise how good we've got it. I know they're frustrated, and I know sometimes you might have to wait longer than you would like for an ambulance to show up at your front door. But you're talking about a country that I've come from where an ambulance system simply does not exist. It's also taught me to be a lot more resourceful as well. Working overseas, you didn't always have the luxury of just shooting back over here to grab something that's just readily available. I had a Pelican case and a backpack, and that's kind of it. So having the luxury of a big shiny box sat outside on the driveway with everything in it is, is brilliant. And I've utilised all of those resources on every patient to make sure we get the best medical picture I can.
The position that we're in, that we do have access to all sorts of resources, that we don't appreciate them, and that we probably don't utilise them as well as we could.
So I think I really enjoyed working with FFT and REACH because it has given me a complete insight into, first of all, how unequal medicine is delivered in the UK, and especially with regards to people from a Black and ethnic minority background. And just it's really triggered an interest in sort of the unconscious bias side and the sort of trying to tackle all those issues that are quite inherent in our system as well. So I'm much more aware of my own privilege when I am treating people who have come from more of a vulnerable background than me. I also feel it's got a bit of a wider implication. So if you are interested in working abroad, I think it's really, really important to actually understand that background of the inherent bias that we have in our system and in medicine and as doctors that we're not really aware of, in order to really work with your eyes open when you do go abroad.
It does mean when I get patients coming into A&E and juniors are managing them, I try to make sure they're sensitive to some of the broader contexts around global EM presentations, particularly in urban settings where we might have asylum seekers, refugees, or as well just other migrant patients from other backgrounds. And just to be considerate to the variations in health culture and health behaviours and health literacy that other people might have, and how that might impact the way we manage their case.
I've been used to working in a supportive team over in the UK, where there's always somebody to run your decisions past, and you don't feel like you're taking that responsibility on your own. When you're working alone or as part of a small team, you have to make those decisions, and you have to make them quickly, and you have to learn to deal with the consequences of what you've decided.
However, I was working much more autonomously and with less support than I had done previously, as 2 of the hospitals had no paediatrician cover.
So what it does is it allows you to put things really well into perspective. It allows you to, I think, have an inner resilience and calmness when other people may, for example, in emergency departments, which is my background, be losing it a little bit when it gets really, really busy, which it does. I think it gives you that calmness and that ability to see through it and make sure that you deliver the best patient care in the circumstance you have, because that's what you have to do in global healthcare, regardless of the equipment or the staffing that you have.
I think that the global health work has really helped me as an ODP to broaden my mindset when I look at a problem. So I was always solving immediate problems within my work in practice, and then I would quickly be like, oh, well, so-and-so hasn't done such and such. But now, like, if it's, radiology or ICU or the A&E or the community, I have a great more patience and understanding, and I have a much more interest in how you solve a problem. So if I have a problem in theatre, is a problem in theatre, or is a problem in A&E, is it in ICU, is it with staffing levels? I think I have a much better scope and grasp of sort of healthcare holistically than I did before. And I certainly find that I'm far more adaptable because we are so well resourced in the UK and we are not so well resourced in other places. So it's helped me become a better problem solver. It's helped me become more adaptable, and it's helped me just be a better practitioner, really, if I'm honest.
Something that's absolutely come to the fore in the last, we had some savage bushfires in late 2019, early 2020, and then switched straight into the COVID response. So people's mental health and that emotional intelligence, I think, is really important, and it's something I brought back from being overseas into the normal job.
I'm also more aware of the long-term impact of the decisions we make in healthcare, and how some of the things that we might decide to do in an emergency situation may not be right in the long term for particular patients.
Something like the blast in Manchester can create similar challenges, and I think we've got very, very good at managing those challenges on from an emergency care perspective, from the pre-hospital and the emergency department, and perhaps not quite so good always in the UK and globally at thinking about the full continuum of care and how we need to start thinking about that, really, I think, as part of the preparedness planning in greater detail. And I think COVID has shown that as well to a strong degree. I think in emergency settings, one of the key things is that the responsibility for ensuring best outcomes for patients really runs throughout the team. So, if you're working in a country where there was already relatively poor rehabilitation service coverage, and then you put in an earthquake or a conflict on top of that, typically what happens is that then just is neglected, and it really falls often to people working in emergency care or in surgical care to sort of flag those issues and raise them and advocate for them. And I think it's often much more powerful to hear from those kind of allies in these settings than it is for the rehab people to be advocating for the importance of rehab.
One day I really hope to become a pharmacist that is a fully integrated member of the global emergency response team, and one that is able to face any situation anywhere in the world.
When it comes to what's next for me in global emergency care, I'm not really sure. I've got 2 young boys at home, one of which is just 10 weeks old, so I will be spending a lot of time just being mum for a while. I would like to stay in touch with the UK emergency medical team and also with Capital Air Ambulance, but I imagine that will probably be more as a supportive UK-based role rather than going out into the field, certainly for a while.
I have a real interest in delivering long-term sustainable solutions in countries. I'd really like to do something along the sort of capacity care delivery again, a bit more of a mix. And I'm hoping that I can hopefully find another organisation that's looking for someone that could help organise that, and maybe even step up to helping to coordinate a bit more, with maybe the lead of a team or something, because I feel I've got a lot to give in that area.
So I'm on the UK Med register now, so that kind of offers a nice little kind of an ability to still keep my feet in and work abroad, because it's a small chunk of 3 weeks out of every year that you can work abroad. I've also recently joined, become a forensic physician for the Sexual Assault Referral Centre, so I've got quite an interest now in sort of the forensic physician sides, documenting torture and human rights issues behind it, and it's an area I'm kind of keen to build on. There's the emphasis actually on being a mum and having kids, and that shouldn't stop you. My family are my enablers. They don't hold me back at all, but they support me and champion me, and that's really important to acknowledge them as well in helping me get as far as I've got. I don't think I'd do it on my own.
My next short-term goals in global emergency care are essentially to get more involved again, because I've had to take quite a step back also been doing that ACP training?
I am looking at doing a secondment at the moment with the World Health Organization. And if I'm successful in getting that position, it'll be initially a 6-month contract looking at shoring up the emergency medical team response in all the small islands around the Western Pacific.
For me, it's about personal development, as well as developing my colleagues both in this country and abroad, as well as trying to help. It's a bit corny perhaps, but trying to help people in less privileged circumstances than we are. Oh, there we go, you see, power cut. Life in the field